So hello, welcome. This is a good morning for me, but good afternoon, good evening to those of you coming from other time zones. My name is Heather Wakely, and I'm the ISSC President-elect. I'm also a professor of medicine and the Division Chief of Medical Oncology at Stanford University and the Deputy Director of the Stanford Cancer Institute. I, along with the panelists, will be discussing the effects of the COVID-19 pandemic on lung cancer care and advocacy, and really the impact on the patients themselves. Ms. Ivy Elkins, good friend, is our patient advocate panelist. She was diagnosed in 2013 at age 47 with EGFR positive stage 4 lung cancer. And at the time, it had metastasized to her bones and brain. She's been treated successfully, though, with targeted therapy medications since her diagnosis, had a lobectomy for oligometastatic disease remnant back in 2020, and currently is considered to have no evidence of disease, which we affectionately call NED, or at least some of my patients do. Ivy is one of the founding members of the EGFR Resistors Lung Cancer Patient Group. She has served as a consumer reviewer for the Department of Defense Lung Cancer Research Program and Conquer Cancer. She's completed the AACR Scientist Survivor Program and acted as faculty for the ASCO AACR Methods in Clinical Cancer Research Workshop. And this is a really key workshop training program. She also is a current mentor in the IASLC Supportive Training for Advocates on Research and Science, also known as the STARS program, which aims to increase the number of patient research advocates for lung cancer globally. And this is done through critical science training to prepare them for providing patient perspectives in lung cancer research and policy. In addition, Ivy is a member of both the Patient Advocacy Committee and the IASLC Lung Cancer News editorial group. So she's incredibly involved with an IASLC and an amazing advocate. I'm going to ask that you please hold your questions until the end of the press conference, at which time you can ask live or via chat. We're going to start the presentation with Dr. Roxana Reyes and her presentation on COVID-19 and the impact on lung cancer diagnosis and prognosis. And just to give you a little bit of background, Dr. Roxana Reyes, she is an MD, but a pre-doctoral student in the Thoracic Tumors Unit of the Hospital Clinic in Barcelona. She is working to complete her degree in medical oncology at the National Center for Oncological Research, or CNIO. In addition to her doctoral thesis project, Dr. Reyes also has maintained her medical practice and patient care, and she's involved in several clinical and translational research projects. So Dr. Reyes, please take over. And I'll just also mention that in addition to that work, she has done a lot of work in organizations, including the Lung Cancer Group of the European Organization of Research and Treatment of Cancer, also known as EORTC, the European Society of Medical Oncology, or ESMO, the Spanish Society of Medical Oncology, CEMO, and the International Association for the Study of Lung Cancer, of course, IASLC. So now we'll let Dr. Reyes take over. Thanks.
Thank you very much. Okay, I will share my presentation. Oh, you can see the presentation.
Yes, we can see it.
Okay, thank you very much. Good day to all. On behalf of all the authors, it's my pleasure to be here today to present our study. So these are my disclosures. And as you know, the COVID-19 pandemic is devastating, and it impacts around the world, and Spain was one of the most affected countries. One of the most vulnerable population is the group of cancer patients with high severity and mortality reported, in particular those with lung cancer. So in Spain, during the first and second wave, the state of emergency forced the prioritization of health services which could delay the diagnosis and treatment of cancer patients. Hence, our objective was to study the lung cancer's incidence, severity, and clinical outcomes during COVID. This is a retrospective study of newly diagnosed non-small and small cell lung cancer seen in medical oncology consultation from 2 centers in Spain. We collected data of new cases in 2 periods, during COVID and the same period in 2019. So we primarily assessed the difference between incidence in both periods and the severity of the disease, considering PS, stage, and any significant complication at diagnosis. Secondarily, we studied the 30-day mortality rate by period and by histology group. 162 patients were enrolled, and we observed a decrease in the incidence by 38% during COVID. On the right, you can see the main baseline characteristics of this population, in red during COVID and in blue before COVID. These were quite similar in both groups. The median age is around 66 years old, mainly male patients with PS 0 or 1 and with an advanced stage of the disease. Only the proportion of non-smokers was higher during COVID. 110 were patients with non-small cell lung cancer. In this group, we observed a decrease in the incidence by 36%. And in terms of the severity of the disease, we observe a higher proportion of oncologic emergency, hospitalization, death during hospitalization, advanced disease cases, high tumor burden, and symptomatic illness during COVID. So globally, in this population, patients had a more severe disease than before COVID. 52 patients were diagnosed with small cell lung cancer, and in this group, the incidence decreased up to 42% during COVID. As you can see, in contrast to the non-small cell lung cancer group, we didn't find a higher proportion of severe disease during COVID. So in these figures represent the incidence per month in each histology group and in both periods. During COVID, the incidence per month was lower, with no rebound effect observed in the incidence of non-small cell lung cancer, in contrast to the small cell lung cancer group with an increase of the incidence post-COVID's first wave. So, as the overall survival data is still immature, we assess the early death, the 30 days mortality rate, which almost doubled during COVID in comparison with 2019 in both histologies. To conclude, lung cancer diagnosis is being affected during COVID with a drop of 38% of new cases. In non-small cell lung cancer, more symptomatic and severe cases were diagnosed, but not in small cell lung cancer. However, we observed poor outcomes during COVID with a higher early death rate. And finally, COVID-19 pandemic is likely to last for a prolonged period of time, so we have to make a special effort for ensuring the cancer diagnosis and treatment of our patients. I would like to thank patients and families and all the researchers in the 2 centers, and thank you for your attention.
Thank you, Dr. Reyes. And again, we're going to hold questions until the end when we've gone through all of the presentations. So our next presentation is going to be by Jessica Selig. Ms. Selig served as a research fellow during the summer of 2020 at Longevity, so in the Longevity Foundation, so one of the premier advocacy groups, and she's going to be presenting work from that time. She has since moved on to a role unrelated to this presentation as a clinical research associate in digital medicine at Pfizer, and her focus and research is in patient-reported outcomes, or PROs. So, Ms. Selig, and you're on mute right now.
Are you able to see my slides?
Yes.
Wonderful. All right. Thank you very much for the introduction, and thank you for including the longevity abstract and for inviting me to give a brief overview of our work. My name is Jessica Selig, and I'm representing the Longevity Foundation and my fellow authors, Marjorie Jacobson and Dr. Upal Basu Roy. Longevity is a national U.S. patient advocacy organization whose vision is of a world where no one dies of lung cancer. I have no relevant disclosures. We conducted a post-shelter-in-place needs assessment of lung cancer patients in the United States in order to learn lessons from the impact of the COVID-19 pandemic on the lung cancer community. Despite the fact that this survey was conducted in the United States, the results of this study are global in nature and have implications for the rest of the world. A little bit of background on why we conducted this study and the timeline behind it. The first case of COVID-19 occurred in the United States in January of last year. In March, the World Health Organization declared COVID-19 a pandemic, at which point many parts of the United States went into lockdown and shelter-in-place orders and other restrictions were put into place. As summer approached and cases began to reduce and the curve seemed to be flattening, many parts of the United States reduced shelter-in-place orders, lifted other restrictions, and lockdown was eased. So that was in May of last year, at which point in June, assuming the immediacy of the lockdown was over, it was important to understand the post-shelter-in-place special needs and concerns of the lung cancer patients, given the fact that despite the fact that the world was opening back up and things were opening back up, the risk for lung cancer patients when it came to contracting COVID-19 was not decreasing. I will give a high-level overview of the results from this study now, but I'll go into greater detail in my presentation during the conference tomorrow. Unsurprisingly, given the nature of the pandemic, 96% of all respondents expressed some level of concern when it came to the impact of COVID-19 on their cancer care. We conducted further analyses based on a breakdown of patient-specific factors of treatment status, age, and residing in a COVID-19 hotspot, which I will delve deeper into further detail about in my conference presentation. When asked qualitatively about their concerns in the post-shelter-in-place environment, lung cancer patients responded that they were very scared of contracting COVID-19 given their higher risk for more severe cases of COVID due to their lung cancer. As the country was coming out of lockdown and restrictions were easing up, they expressed concern about going into their doctor's office for their cancer care. With the lifting of restrictions, 44% of respondents reported some degree of concern and worry about accessing care and other cancer treatments post-shelter-in-place. So why is this study important? It is important to be aware that the lung cancer community is facing the pandemic with greater urgency due to their higher risk with developing more severe cases of COVID-19. Patients indicated through our survey that they were very worried about going into their doctor to get infusions, other treatments, x-rays, and other forms of treatment that are necessary for the maintenance and treatment of their lung cancer. Longevity emphasizes the importance of keeping patients in mind when planning healthcare delivery. Lung cancer patients need to feel safe and secure when accessing their treatment, and COVID-19 is a big threat to the lung cancer community given their higher risk of more serious complications. As it stands right now, patients are not prioritized when it comes to vaccinations. Therefore, Longevity believes that since patients are an incredibly vulnerable group, patients, particularly those residing in high caseload areas or COVID-19 hotspots, should be prioritized when it comes to vaccinations. We also do need to keep in mind that this study was conducted in June of last year before we experienced greater spikes, more deaths, and further complications from the fast evolving pandemic. At the time, we did not ask participants in our survey about vaccines because this was back in June and much has clearly happened since then when it's come to the pandemic. Therefore, it may be beneficial to resurvey this population, given that some of the concerns I went over and in the findings of this study would likely have only become worse given the progression of COVID-19 and the current state of the pandemic. Thank you very much.
Thank you, Ms. Selig, for that great presentation. Okay. Our next speaker is Professor Matthew Peters, who is a respiratory physician based in Sydney, Australia, with academic appointments at Macquarie University and the University of Sydney. He has been involved in lung cancer patient education and advocacy for more than 25 years. Lung Foundation Australia recognized his contribution in 2017 with the Lifetime Achievement Award. He's been chair of the Global Lung Cancer Coalition since 2006, during which time there has been a great expansion of its role, range of activities, and geographic coverage. Welcome, Professor Peters. All right.
Just trying to share my screen, or are you doing it for me?
You'll need to do it.
It said the host disabled participant screen sharing when I try to share.
Okay. Let's see.
Chris, do you want to put his slides up for him, please?
Yeah. Thanks, Joy.
I just made you co-host. I just made you co-host.
Oh, okay. So I
It's
can
gonna work now.
Yeah.
Okay.
Sorry about
Good.
that.
Thank you. All right. So we've just heard from the previous presenters of the personal impact of COVID. The Global Lung Cancer Coalition is an alliance of charities that are focused on patient support, education, and advocacy. And so we looked at it from the point of view of what is the impact of COVID-19 on these organisations and what they're able to offer. They're a key part of service provision for lung cancer alongside existing health structures. Okay. So the Global Lung Cancer Coalition is funded along the sustaining partner model from a range of pharmaceutical companies. As listed, I personally don't have any relevant conflict of interest, and in reality, our sustaining partners had no influence in the design. So we have 40 patient organisations across 29 countries, including Australia, where it's 2:30 in the morning. And good morning, everybody. Our members play a role, as I mentioned, and we needed to understand and support our members in terms of continuing their range of activities. So we designed a simple 15-question survey based on a number of themes: demand from patients, the patient's needs, the changes to the services that can be offered, and the impact on each organisation's finances. Now, this was conducted in April and May 2020. So, depending on which organisation, different countries may have at that time been in different phases of the COVID epidemic, and it's relevant to the impact of organisations at that time. So we got 23 responses from a wide range, and really it's not a quantifiable outcome, but just describing the range of impacts organisations felt. So firstly, and again, not surprising based on the previous presentation, they had increased requests from a range of access modes, from telephone to the website and Facebook. Concerns about the risk of contracting COVID-19 and the implication of treatment delays, and that's reflected in some of the previous presentations you've heard. Various organisations, including those that partly fund their services through retail operations, had a substantial decrease in their income. Those who are supported by personal donations were impacted by job losses that occurred early in the COVID-19 epidemic. And only 5 of the 23 responding organisations had any additional support from national or regional governments to keep their financial structures. Again, as we've lived this epidemic, two out of three organisations had to alter their face-to-face practices, and I just have to anyway. So it was very difficult for our organisations to keep the same level of activity and to keep their role going, important as we believe it to be. So what's the key away thing is that patient organisations are being asked to provide more support during the COVID-19 pandemic at a time when many are doing with decreased resources and loss of critical staff. We're just about to embark on the follow-up survey, which will be sent out towards the end of next week, and will include, as relevant, questions in relation to vaccination and how they're doing in terms of ensuring that lung cancer patients who we know have a higher risk of COVID-related severe disease and mortality are getting appropriate priority based on risk in national vaccination programs. So, thank you very much for your attention.
Thank you, Professor Peterson. Thank you for being up in the middle of the night to be with us. All right, we'll now move on to Stephanie Nguyen. She is a physiotherapist in thoracic prehabilitation at Guy's and Thomas in the National Health Service Foundation Trust in London in the UK. She has special interest in the management and prevention of thoracic cancers and chronic respiratory conditions through physical activity, and activity change interventions. She volunteers as part of a new community of practice group aiming to improve the early diagnosis of lung cancer in patients in Southeast London, UK. Ms. Nguyen?
Thank you very much. I'll just try and share my slides now. Can everybody see that okay?
Yes.
Yeah, perfect. Okay, well, thank you very much for inviting me to speak today. And the title of my abstract is Providing Thoracic Prehabilitation During COVID-19, a review of a virtual model. And I'm here presenting on behalf of Guy's Hospital Cancer Centre in London. I do not have any relevant financial relationships to disclose. So lung resection surgery is the most common radical treatment for lung cancer, yet only 10 to 30% of individuals referred are candidates for radical treatment due to their disease stage and a number of surgical risk factors, including advanced age, poor performance status, high comorbidities, and reduced cardiopulmonary reserve. Prehabilitation, or prehab, is the practice of enhancing a patient's functional capacity before surgery with the aim of improving post-operative outcomes. And in lung cancer surgery, it's associated with improved functional capacity and quality of life and reduced hospital length of stay, post-operative complications, and readmission. But prehabilitation is predominantly delivered via supervised exercise programs. However, since the COVID-19 pandemic, capacity to deliver face-to-face hospital appointments has significantly reduced. Therefore, we present preliminary data from a new remote prehab service for patients undergoing lung surgery at a busy National Healthcare Trust in London. In terms of our methods, 20 patients were prospectively recruited from surgical lists over a 6-week period, and each patient was offered a prehab assessment over video or phone. An assessment involved outcomes that could be completed remotely, and this included the Rockwood Clinical Frailty Scale, the MRC Dyspnea Scale, the Godin Leisure Time Exercise Questionnaire to measure self-reported physical activity levels, a screening tool for malnutrition, the Hospital Anxiety and Depression Scale, and the Facet Fatigue Questionnaire. And in addition, we used the 1-minute sit-to-stand test to measure patients' exercise capacity remotely. And following assessment, each patient received a personalised home exercise programme to complete within the home, and written advice and counselling for specific symptom management. Telephone or video follow-up then occurred weekly, and an end of prehab assessment was completed before surgery to repeat some outcome measures. Due to a local policy change during our pilot service, some patients were permitted a one-off face-to-face visit to the hospital to be assessed, but their intervention and follow-up continued remotely. In terms of our baseline characteristics, 65% of our cohort were female, with a mean age of 68 years, performance status of 1, MRC Dyspnea scale score of 2, and an FEV 1% predicted of 86. 70% of the cohort had a smoking history, with a mean pack year history of 20. 45% of the cohort had 5 or more comorbidities. 15 were classified as vulnerable to mildly frail, and 40% were classified as sufficiently active in terms of their physical activity levels at baseline. And the types of surgery performed are demonstrated here. So in terms of our results, the uptake rates for patients approached for remote or face-to-face assessments were 64% and 100% respectively. 75% of participants had access to email or video technology, whilst 25 could only receive telephone calls or written handouts. Inability to access emails or videos was noted in all patients over the age of 80 and patients with high-risk therapy needs, meaning a falls history, balance impairment, pain, or a high symptom burden, also tended to have less access to technology. 14 patients from our pilot completed prehab through to an end of program assessment with a mean intervention period of 27 days. At end of prehab assessment, there was no change in dyspnea, HAD score, or fatigue. However, a mean change of 50 points was observed on the Godin Leisure Time Exercise Questionnaire, with 100% of the cohort meeting the recommended levels of physical activity post-intervention. Further, we observed a mean change in the 1-minute sit-to-stand test of +6, which exceeds the minimum clinically important difference for this measure in COPD. So to conclude, our findings demonstrate that remote home-based prehab is feasible and may improve patients' pre-surgical physical activity and exercise capacity. And we feel that this is pertinent given the ongoing uncertainty surrounding COVID-19 and its impact on face-to-face healthcare delivery. Further consideration regarding the delivery of safe and effective remote prehab to more elderly or vulnerable patients may be required. And we're therefore designing a triaging tool to best support patients based on their therapeutic needs and access to technology. Thank you very much for listening to my presentation, and also thank you to the wider team at Guy's Hospital who've supported this pilot.
Great, thank you very much. We are now going to move on to Dr. Umit Tapan. Dr. Tapan is a thoracic oncologist and assistant professor of medicine at Boston University Medical Center in the United States. Dr. Tapan's research interests include racial disparities in cancer care and outcomes, and the microbiome and cancer immunotherapy. In full disclosure, I am part of the TerraVolt steering committee and an author on this paper that will be discussed. Dr. Tapan?
Good day to everyone, and thank you for the opportunity of speaking to you today. I will be presenting the abstract on behalf of TerraVolt investigators. As you might know, COVID-19 outcomes were found to be worse in lung cancer patients. So TerraVolt initiative was started back in March. Actually, let me make sure to mention that I do not have any relevant financial relationships to disclose. So the idea of making a database for COVID-19 patients with thoracic malignancies was initially discussed back in March 15th, 2020. And then shortly after, a RADCAP was created. And then as end of March 2020, the protocol was approved and first patient data was entered. Within 2 weeks, 200 patients were entered, and within 2 months after that, the first report was published in Lancet Oncology, showing very high mortality in this patient group at 33%. As of August 2nd, 2020, more than 1,000 patients were included in this database, coming from 20 countries and more than 100 hospitals. As of mid-September, data was presented at ESMO, showing that the mortality continues to remain high at 32%. And during this ESMO presentation, from the data that was obtained by TeraVolt, a nomogram was created that could predict mortality from COVID-19. And here, towards the end of January 2021, sorry for the mistake there, it says 2020, we have more than 1,500 patients from 31 countries, and second manuscript is in preparation at this point. So the mortality model that was presented at ESMO shows that patients with higher ECOG performance status, higher cancer stage at the time of COVID-19, being former or active smoker, use of prior steroids, older age, and receiving oncological treatments had an impact on the mortality, as you can see in this table. When we come to the current study that I will be presenting, as you know, this has been mentioned many times, cancer patients are especially vulnerable to effects of COVID-19, and patients with thoracic cancers are more likely to suffer from complications of COVID-19. Possibly due to older age, smoking habits, and pre-existing medical conditions. Previously reported by TeraVolt investigators, patients with thoracic cancers had lower ICU admissions and increased death rate. And several studies have been conducted since then showing that gender, race, and ethnicity could also impact COVID-19 outcomes. Studies have revealed that male patients have higher death rates compared to female patients, and hospitalization rates and death rates were found to be similar between African Americans and white patients. In this current abstract, we are reporting COVID-19 outcomes in thoracic cancer patients according to gender, race, and ethnic groups. This is the baseline demographics for our entire cohort. As you can see, more than 1,000 patients were included from 19 countries and 120 centers. Most of these patients were included from Europe, followed by North America and South America, Australia, Asia, and Central America. Majority of the patients were with non-small cell lung cancer, followed by small cell lung cancer and other thoracic malignancies. In this bar graph, you can see that majority of patients were male, majority of them were white, and most of the patients were non-Hispanic in ethnicity. In order to assess the death rates and hospitalization rates, a multivariable analysis was performed. As I mentioned, 1,011 patients were analyzed. 33% death rate was noted in the whole population. Based on the multivariable analysis, higher death rates were seen in male patients, in older adults, patients with worse performance status, patients with cancer spread to more than 3 organs. Similarly, higher hospitalization rates were also seen in males, older adults, patients with worse performance status, and cancer spread to more than 3 organs. The only difference here was receipt of radiation therapy during preceding 3 months of COVID-19, which was found to increase the rate of hospitalization, presumably because of potential radiation-related changes in the lungs for these patients. Death rates and hospitalization rates were similar among different racial and ethnic groups. Important to note that 72% of the patients were white and only 8% were African American. In terms of the conclusion from this study, death rates remain very high in this vulnerable patient population at 33%. 1 in 3 patients, unfortunately, died from COVID-19. This underscores the importance of COVID-19 vaccinations in patients with thoracic cancers when available. In our institution, we are fortunate that now we are able to offer COVID-19 vaccine in this patient population. As I mentioned, older age, being male, having worse performance status and cancer spread to more than 3 organs increase mortality. Similarly, hospitalization rates and race and ethnicity did not seem to affect death rates or hospitalization rates in multivariate analysis. I would like to acknowledge all contributing Teravolt investigators. I would like to thank to our patients and their caregivers, and to all healthcare workers in their fight against COVID-19, especially my colleagues at Boston Medical Center, and to my family for their support. Thank you.
Thank you, Dr. Tappan. Okay, and now our final presentation of new data, and then we get to hear from Ivy Elkins. But today, right now, we're going to hear from Dr. Dominico Galetta. He is the head of the Medical Oncology Unit for Thoracic Diseases at the Clinical Cancer Center IRCSS, or Giovanni Paolo II, in Bari, Italy. Dr. Galetta started the first thoracic oncology clinic in the Puglia region in 2010, which has quickly grown to some 500 new patients per year. He has been involved with more than 40 clinical trials on pleural pulmonary pathology, many of which led to drug approvals in Italy. He is currently directing 22 clinical trials. Dr. Galetta has been a presenter or speaker at every World Conference on Lung Cancer since 1994 and is a very valued member of the society. Please take it away, Dr. Galetta.
Thank you. It's all okay for the vision?
Yes.
Okay. Thank you at all. Thank you, President-elect. And thank you for considering our contribution. My speech is on the behalf of the Oncology Institute Giovanni Paolo II of Bari, Italy. And the topic is the evaluation of psychological distress in outpatients with lymphoma, lung, and breast cancer during first wave of COVID-19 pandemic. These are my disclosure. And as we know, the anxiety, depression, fear, and the typical symptoms of post-traumatic stress disorders have been widely detected during the COVID-19 pandemic in the general population. But the impact of pandemic on cancer patients is still lacking. Indeed, the SARS-CoV-2 pandemic has had a terrible impact on cancer patients due to the reduction of hospital activities, for example, decline in outpatient activity, the reduction in available beds, and in the load of clinical activities, the postponing of cancer screening tests. And furthermore, there is an increasing risk of a severe outcome in cancer patients than in the general population. According to these premises, the aim of this study is to assess the psychological status of outpatients undergoing anti-cancer treatment during first wave pandemic in a no-COVID hospital. In particular, we want to measure the level of general distress, depression, anxiety, and post-traumatic distress symptoms and worries in cancer patients, and to evaluate mental health measures according to cancer symptoms. These are the data, the results. 176 consecutive patients, cancer patients, were included when admitted to our institute. 77 with lymphoma, 59 with lung cancer, and 40 with breast cancer. We adopted this measure, HADS, listen before, Hospital Anxiety and Depression Scale, used to measure the level of general distress, depression, and anxiety. The impact of Evans Scale Revised, used to measure the post-traumatic distress symptoms, and regarding the COVID patient lives, we used a brief structured questionnaire for worries. So these are the results. We found that 55% of patients have high level of general distress, 58% high level of anxiety, and 44% have high level of depression. But what is important is to note that about a quarter of patients report severe symptoms of post-traumatic stress disorder, and women have been found to be significantly more vulnerable to post-traumatic stress disorder, and this datum seems to be confirmed in previous literature. About 70% of patients declared that their worries increased during the pandemic, especially the risk of getting an infect while at hospital, the risk of infecting the relative coming back home, the risk of delaying therapy, or the social distancing from their loved ones. Only few patients give their answer regarding the distancing for oncologists or the financial problem. It emerged that they are prevalent in the female gender. Finally, we know that higher levels of depression, anxiety, and general distress were found in lung cancer group in comparison to breast cancer and lymphoma, probably for the impaired respiratory function in this patient. And this is significantly for lung cancer patient. In conclusion, we think that it is very important to protect cancer patients as one of the main components of public health measure. But special intervention are to promote mental well-being in patients need to be implemented as soon as possible, especially with regard to women and lung cancer patients. Many thanks for your attention and many thanks for your considering our message. Thank you.
Thank you, Dr. Galetta. And now I'm going to turn it over to my co-host and patient advocate extraordinaire, Ivy Elkins.
Hi, everyone, and good morning from Chicago. Thank you for the lovely introduction earlier, Dr. Wakely, and thank you for including me in this press briefing. I really appreciate the opportunity to share my perspective as a lung cancer survivor and patient advocate about the important research being presented at this conference on COVID-19 and lung cancer. I'd like to start by asking everyone to imagine for a moment being a patient diagnosed with lung cancer. Maybe you were newly diagnosed, maybe you were in active treatment, maybe you have completed treatment but still go for follow-up scans. You're already afraid, either due to your new diagnosis, your need for treatments that frequently lead to side effects and uncertainty, or your worries about recurrence. Then add a new disease to the mix that usually impacts the lungs, COVID-19, and other respiratory disease in addition to lung cancer. Since the pandemic started, patients living with lung cancer have been impacted both mentally and physically, as much of the research presented at the conference shows. Psychological distress in the form of increased anxiety, depression, and even PTSD and suicide risk is significant in the lung cancer community, no matter where patients live. This was true even before COVID-19. With additional concerns about how COVID will impact their cancer care and fears of complications or death if contracting COVID, it's not surprising that patients with lung cancer have reported increased needs for support and information and greater impact on their mental health. The need to follow shelter-in-place orders and social distancing recommendations has caused significant distress for everyone. Imagine, again, that you are a patient with lung cancer. While already living with the knowledge that you have a shortened lifespan, the pandemic prevents you from seeing loved ones and enjoying the normal activities of daily life. This is time that those of us living with lung cancer will never get back. As someone who has been living with stage 4 lung cancer for over 7 years, the knowledge that the future is never guaranteed is always a part of my life. Through over 7 years of targeted therapy treatments, I've lived my life in 3-month intervals between scans, trying to always focus on the present. I've been fortunate to thrive with treatment, but I know changes to my health could always be just one scan away. Last February, just 1 month before the pandemic hit, I had a lobectomy to remove my upper right lobe, the site of oligometastatic remnant disease, and became NED, no evidence of disease, for the first time since my journey began in 2013. I know that I was incredibly lucky regarding the timing of my surgery. If it had been planned for even slightly later in the year, it would have likely been deemed an elective procedure and not taken place. Since my surgery, I have seldom left my house due to my own fears about COVID-19. I haven't even seen or hugged my 89-year-old mother since March due to the multiple risk factors we both have. It greatly saddens me that for the past year, a year in which I remained NED, no evidence of disease, I have not been able to take advantage of my health and truly experience life. It has been almost impossible to focus merely on the present and not worry about the future. It's heartening to hear about how many lung cancer patient advocacy organizations have pivoted their programming to support patients like myself by adding online services such as webinars, podcasts, and increased helpline hours when in-person events needed to be canceled due to the pandemic. Online programming like this is critical for people with lung cancer to feel less alone, get their questions answered, and access trustworthy information to help manage their worries and anxiety. It is very concerning that some of these same organizations that are so critical to the wellness of the lung cancer community might be dealing with their own financial issues and questions about survival. Meeting others living with lung cancer through Longevity and other patient advocacy organizations was life-saving for me when I was diagnosed. There is nothing that can provide more hope to a lung cancer patient than connecting with others going through similar things, especially those who have persevered and survived with their cancer for a long time. I cannot imagine not having that type of support available to me. It was instrumental to my learning to advocate for myself and ultimately to become an advocate for increased lung cancer research and awareness. As someone who encourages other patients to seek out medical attention at the first sign of any concerning symptoms, it's extremely worrisome for me that COVID-19 has led to delayed lung cancer diagnoses, with increasing numbers of patients presenting with more advanced disease and higher symptom burden. It's completely understandable that patients are concerned about seeking treatment due to fear of contracting COVID and bringing it home to their loved ones. However, this delay can make the difference between life and death for many of us. Imagine you have a cough that just won't go away. You've been tested for COVID and you're relieved that you are negative. The COVID-19 pandemic is booming, and since your cough is not COVID, you might decide that it just isn't that big of an issue and isn't worth potentially contracting COVID by having it checked out further. It would be very easy to delay a visit to a doctor. That cough, as we all know, could be an early indication of lung cancer. When I was diagnosed, I didn't have a cough. My only symptoms were a stiff elbow and neck pain. It took me 6 months, constantly pushing for answers, to get a completely unexpected lung cancer diagnosis. What if this had been during the pandemic? I'm not sure I would have kept going to the numerous appointments with orthopedists, physical therapists, and rheumatologists that I visited before getting an answer. Instead, I might have believed my primary care physician, who told me that I was just getting older at 47 and had an overuse injury from too much electronics. Instead of being here today speaking, it's likely that the large tumor I unknowingly had on my cervical spine, which was causing my neck pain, would have ultimately caused my spinal column to collapse. I would have died in my sleep, as a neurosurgeon I saw soon after my diagnosis told me could have happened. While not every delay in diagnosis will make the difference between life and death, delays can still have significant impacts on treatment and quality of life. Lung cancer has the best chance of being cured when it is diagnosed early. With more advanced disease, biomarker testing is needed to determine the best possible treatment. However, these tests can take a number of weeks post-diagnosis to return results. Patients who are very symptomatic might not be able to wait for these results to be returned and might be placed immediately on chemotherapy or immunotherapy due to their high symptom burden, as opposed to waiting to select the most appropriate treatment after a full next-generation sequencing panel workup. This can lead to less effective treatment and negatively affect overall survival. Once diagnosed, many patients in this new pandemic world may be seeing their healthcare practitioners through telehealth visits. Having access to telehealth has made it possible for many patients to continue their care without need for travel and with reduced exposure. Creative uses of telehealth, such as the surgery prehabilitation discussed, have made things easier and safer for both patients and healthcare workers. I truly hope that telehealth will continue to be an option covered by insurance for patients in a post-COVID world whenever practical. However, care will need to be taken to make sure that technological advances don't increase disparities of care because of the difficulty in using or having access to telehealth experienced by diverse subpopulations of patients. My mother, similar to the older patients in the prehabilitation study, would never be able to have a doctor's appointment via telehealth. I'd like to conclude by touching on the biggest topic currently concerning most patients living with lung cancer, COVID-19 vaccination. While some patients have worries about getting vaccinated, the majority of oncologists are encouraging their patients to be vaccinated, and evidence points to an overwhelming advantage to getting a COVID-19 vaccine for nearly all patients. Accordingly to recently issued NCCN guidelines, COVID-19 vaccines should be given to all cancer patients, as well as household contacts and caregivers when they are eligible to receive the vaccine. We know from studies like TerraVault how significantly COVID-19 has impacted people with lung cancer, increasing hospitalization rates and mortality. I, for one, will be getting vaccinated for COVID-19 as soon as I become eligible. The true issue now is access. While many oncology organizations are encouraging prioritization of cancer patients for vaccination, individual states in the United States are making their own decisions, resulting in people living with lung cancer now being offered vaccines in some parts of the country while not in others. In my state of Illinois, there are still over 3 million people ahead of me in the vaccination queue. Everyone over 65 years old, frontline workers such as first responders, teachers, grocery store workers, and inmates. I will ask you all one final time to imagine yourself as a lung cancer patient. While desperately hoping to be prioritized soon to get vaccinated for COVID-19, a disease that has upended your already precarious existence for almost a year, you read about others who are failing to show up for vaccination appointments and vaccine dosages that have been unthawed and need to be discarded. How would that make you feel? Frustrated, I'm sure. In addition, in many places, there's lots of uncertainty and confusion about how to even register to get a vaccine. Do we register with our state, our county, our healthcare provider, individual pharmacies or grocery stores? As patients, we look to our cancer centers for guidance, but most have been quiet. We need your help. Please push your cancer centers to provide us with the necessary steps we need to take to assure us of a place in the vaccine line. We critically need you to keep yourselves in the mindset of a patient diagnosed with lung cancer after this press conference is over and continue to advocate for us. On behalf of all lung cancer patients, I'd like to applaud IASLC and the World Conference on Lung Cancer for carefully studying the impact that COVID-19 has had on cancer care and patient needs. I am honored to speak today on behalf of those living with lung cancer and hope I have represented the thoughts and concerns of our community adequately. Thank you for listening.
Thank you, Ivy. That was fantastic. All right, I'm just going to give a few closing comments and then we've got some time for questions. First of all, a thank you to our presenters, all of them. Those were some wonderful presentations. And as I've been listening, there are really some themes that have emerged. So with Dr. Reyes and her discussion about how the severity of the disease diagnosed, of the patients being diagnosed, the severity of disease has gone up. It really highlights that some of the implications we'll be dealing with are not just in the now, but also into the future a bit when we think about reductions in screening also. So we are unfortunately diagnosing more patients with lung cancer at later stages because of the pandemic, and that is going to have some ongoing issues for all of us. Dr. Galetta and Selig's presentations on the patient experience, the impact on the patient's care, as well as the psychological distress, really highlight, again, some critical issues that we all need to be mindful of. And again, these are things that are going to be with us for some time after the pandemic, and bringing forward how the patient experience isn't just about the treatment, but about that whole encounter with the healthcare system, with the fears of their disease and other things ongoing, and that needs to be at our mind front and center as we're helping people who are living with cancer. Then we heard from Professor Peters on the impact of the advocacy organizations, and Ivy also touched on this, where we've had a reduction in the support to the advocacy services, which then help patients beyond just the specifics of their cancer care. But also the message of hope is those groups were able to pivot into a more virtual platform, which theoretically is going to be able to help us to continue to reach more people, but with those challenges of disparity, Ivy, that you just brought up as well. And then as Ms. Nguyen was presenting about the prehabilitation work and how with that pivot to a virtual platform, they were able to maintain a lot of the value of the work that they do. I think, again, that was another message of hope of how we can take the challenges of the pandemic and move forward to be able to offer support to even more people in the future. And then we heard some more updates from the TerraVault, one of many attempts to understand the pandemic in different patient populations, here specifically in those with lung cancer. The concerns, of course, that this disease does have a greater impact on people who are challenged by facing cancer as well, lung cancer as well, that there are disparities there and more that we'll need to understand. To build on that, one of the other questions that we've had during the pandemic is how is this impacting research? Because it's the research that leads to the better treatments of the future. And ISLC right now is in the midst of conducting, and we're just rolling out a survey to ask about the specific impacts on research in lung cancer globally related to the pandemic. And so that will hopefully give us some more insight. As a clinician, I've had to deal firsthand with the impacts of the pandemic, of course, as a patient working in a hospital, but with my patients as well. And some of the things that we've had to implement to try to keep people safer have had really profound psychological impacts. And so it was really insightful for me to hear the others' presentations, because we've had to reduce visitors reduce the support networks that can accompany a patient into a visit. This is particularly profound when people are hospitalized. And it's also limited the strong personal connections that we're able to have. The importance of the healing touch has been taken away from us, and that's something we'll need to grapple this as well as we try to understand all of the health implications, not just the virus directly, but the psychological impacts as well. And now with the questions about the vaccine and how do we roll that out, and then the challenges and the prioritization for people at risk, as Ivy just eloquently talked about, I wanted to echo that as well. So our focus now is to get the pandemic behind us, and that's with work on getting the vaccine distributed globally to enough people to get those rates down so that we can all be safe. And I think that feeling of safety is going to be really, really critical, especially for people living with other health conditions, and for our focus, those living with a cancer diagnosis. We are going to be able to move forward with this new learning about some of the things that we never thought we could do virtually that really we can. But as we move forward, I also want to echo Ivy's comments about how we need to be mindful that that virtual world is not as simple for everyone. We're all now used to spending our lives on Zoom, but there are people who do not have access to computers, where the act of logging in is very challenging, where depending on where you are in the world, not everyone is communicating in the same language. And that also poses its own challenges. So we'll need to be very mindful of not letting those concerns lead to further disparities in healthcare outcomes, and in particular in the world of lung cancer. And with that, I will close and thank you for participating, and not just closing my talk, we do have time for some questions. So please feel free to put in a chat or just unmute yourself and ask a question. I guess we just overwhelmed everybody with all of this new information. So, all right, everyone's muted. So if you do want to say anything, just please come off mute. All right. If not, I'm going to.
Can I ask a question?
Please.
Hi. So Dr. Wakely, since you were part of Dr. Tapan's study, could we get Dr. Reyes to comment on the updated results of the TerraVote trial, please?
Sorry, excuse me, about the terrible study? Okay. We used a terrible study to the data about the severity and mortality reported in lung cancer patients for our study, but maybe I don't understand the question.
My question is, Dr. Reyes, is can you give us your comment on what the results from the TerraVote mean to practicing oncologists?
I'm not sure if I.
Mark,
Sorry.
maybe that's a question for Dr. Tappan to answer.
Well, but I need a commenter. I need a commenter, Chris. I can't use Dr. Tappan to comment on his own study. I've already got those comments.
Sure.
I need an outside commenter, and that's why I asked for. Well, if any other panelist has any other ideas, that would be great. I appreciate it.
Feel free to put that in the chat if you want to connect with Mark after the press conference. Thanks for the question, Mark.
Thank you, Chris.
Oh, maybe I understand that that question was for Dr. Tappan, but sorry.
Yeah, I think that he wanted to get a perspective from a treating medical oncologist who wasn't directly involved in the trial on what does TerraVote mean to us, like as we look at that data. Does it impact how we're treating patients or how we're thinking about the pandemic?
Okay.
Is that the question?
Okay, yeah, I understand, sorry. I think that I see a lot of patients with lung cancer. So patients with lung cancer usually are with a smoking habit and with a decreased lung function. So they are a special population with a high risk of COVID-19 pandemic. So In our hospital, for example, we don't have a screening program, but we use a medical consultation to focus the early diagnosis of cancer, of lung cancer. In this case, during the state of emergency, all of these efforts were to treat the COVID complications. So we lose a lot of patients, and the patients lose the opportunity to be treated. I think that probably in the future, because COVID-19 is likely to last a prolonged period of time, so we have to protect these consultations to continue with a diagnosis of lung cancer in an early stage, because it's a key point, a key factor to a good prognosis.
Thanks.
Thank you. Sorry, it's the problem with English.
Dr. Galetta, do you want to add anything also? As another practicing oncologist.
No. Our trial is only give the suggestion. We have no real conclusion. We give the suggestion to consider lung cancer as more frail as other oncology disease, but probably for the similar of symptoms who have patients with lung cancer and the patients with COVID-19. The important for us is to look at the women who seem more frail into frails in these cases. Only financial financial toxicity is only for men. All the other problems is for women, but the number are so little to give a final conclusion.
Thanks. All right, and we do have a question in the chat for Dr. Tapan. Were you surprised by the lack of difference in outcomes by ethnicity in TerraVolt, especially given the findings in the general population?
I just wanted to comment about the statistical analysis we were able to perform for this abstract. It was multivariate analysis to look for hospitalization rates and death rates as the main outcomes. And when we did that, race and ethnicity did not have a statistically significant impact on hospitalization rates or mortality rates. We are planning to perform further analysis when this becomes a manuscript, but we can say that in general, mortality rates are high in overall thoracic cancer population, but we couldn't find any differences as per ethnicity or race in this abstract.
For Dr. Reyes, I see in you. Hi. I see in your slide on small cell lung cancer, reduced oncology emergencies, reduced, of course, obviously reduced hospitalizations, but also no deaths during hospitalization, reduced advanced disease, and reduced incidence of 2 or more sites. The reduction in symptomatic disease is pretty small. What explains those?
Thank you for your question. That's a good point. In the slide, we describe reduction of the incidence by 42%, and there were no difference in the severity of the disease. I believe that this is explained because the small cell lung cancer is usually presents as an aggressive and in an advanced stage of the disease. Probably the delay in the diagnosis could lead to poor outcome in this poor outcomes in this group of patients, and probably the majority of them couldn't receive an oncologic active oncologic treatment, probably only receive palliative care. So I think that it could be the explanation for that.
But I see no deaths during hospitalization in small cell lung cancer, and I see less advanced disease. So am I reading the slide wrong, or what's going on here?
Yeah, it's because we have a small size of the sample with a very small a small size of the sample in small cell lung cancer. So compared to the year before, patients that were diagnosed with a small cell lung cancer in 2019 probably arrived to the hospital and dead during hospital. So we didn't find in this year patients who died during the hospitalization. I think that because they didn't arrive to the hospital, they only received palliative care.
So you think probably they died at home?
Yes.
Ah.
Because we only consider in our study, we only consider the patients that seen in medical oncology consultation, not all the diagnosis in the other. For example, in the hospice, I don't know how is the name,
yes.
to palliative care units. Yeah, it's like that.
So probably if you had a measure for healthcare contacts, you would see a big reduction there during COVID, and that would explain these other numbers.
Yes, yes.
Thank you.
Thank you.
Heather, Matthew Beach, could I add two other comments there? One is that at least in the first 6 months of the pandemic, patients who may have presented with acute respiratory symptoms have gone off and got COVID tested. And the question in their mind was, have I got COVID? Have I not got COVID? When they got a negative swab result, they regard their problem as being solved rather than going back to their doctor and saying, well, why have I got a cough? So that's going to lead to delayed diagnosis. And the second issue is very clear in Australia and elsewhere, is that the various lockdowns and focus on physical or social distancing, hand washing, has dramatically reduced respiratory viral illness in the community. And unquestionably, respiratory viral illnesses result in accidental early diagnoses of lung cancer. So I think the brilliant work Dr. Reyes has done just shows you that the really symptomatic, more catastrophic lung cancer presentations we're getting are the ones, and they're associated with what we understand from a life's experience of poorer outcomes. And you'd think that as time goes by, we will reap the harvest of those people who didn't get an accidental early diagnosis of lung cancer and have curative treatment. But it's just a very complex time in terms of non-malignant respiratory disease and presentations as well.
Thank you.
Thank you. Yeah, unfortunately, I think that once we have the pandemic behind us, there's going to be a whole lot of people being diagnosed, unfortunately, at later stages than they might have otherwise. So it's going to be some rough time ahead, but hopefully we can be able to move forward. We do have one more question in the chat, and this is for Dr. Galetta. What are some ways that clinicians can address COVID concerns patients have if other interventions are not available? So I think the question is around for a patient living with lung cancer.
Yes. My answer is only to have the chance to have the vaccine as soon as possible, and to give this certainty to the patients. I think is the first therapeutic option, to use the vaccine as soon as possible is therapeutic.
I want to point out to everyone, if you haven't noticed, that Joy has been populating the chat with all of the details about the actual presentations for these, the formal posters, and other ways throughout the conference that you can narrow down to get the specific presentations. All right, and looks like we have, just a thank you for that last question.